Hi there, my name is Jane. I'm going to start with some acknowledgements today. I respectfully acknowledge the past, present, and emerging traditional custodians of the land on which we are meeting, the Whadjuk people of the Noongar Nation. Today I'm going to be talking about anorexia nervosa, specifically during pregnancy and after birth. But I'm going to start with the history of anorexia nervosa. So in 1689 is when the first recorded cases of AN were discovered. However, it wasn't labeled that way. So it was called the wasting disease. And prior to that, it had been considered related to spirituality. So either it was a divine thing to devote yourself and restrict your eating, or it was being possessed or the devil, or it was ill intent spiritually inside you that was making you waste away and not want to eat. And then in 1873, we had a psychopathologist, William Gull. He coined the label anorexia nervosa as kind of an idea of people electing not to eat. And then in 1950, it was introduced into the DSM-1. This was then adapted in the DSM-5 in the 1980s, and two subgroups were created to bring some complexity and understanding to the disorder. Nowadays, eating disorder classification continues to be studied and differentiated as cases rise, and it is rising considerably. So looking at some definitions here, this is just from the DSM. It is lengthy, so I just kept it to the DSM's definition because that's how we would be diagnosing. Anorexia is a persistent restriction of energy intake with an intense fear of gaining weight and disturbed body image. So you need to have all three of those things to be diagnosed according to the DSM-5. From there, there's two types of anorexia nervosa: restrictive eating, which is functioning within a consistent and highly controlled calorie intake deficit. From there, you can have that exact same pattern of eating, so restricting your food, but then episodes of binge eating, purging. That's the other subtype. So that is episodes of eating large amounts and then self-induced vomiting. There's a lot of statistics up there, but I want to look at three. Feel free to pause and take a look at the other ones as well. But the three most important ones to me up here are that around 1 million people in Australia are living with an eating disorder at any given time. Of those, with anorexia nervosa specifically, 75% of people diagnosed with AN are female. So when we're thinking about pregnant mothers and who could be walking through the door, 75% of the cohort with anorexia nervosa are female and could have the potential for pregnancy. So from there, anorexia nervosa makes up the smallest percentage of people living with eating disorders. So only 3% of that 1 million actually has AN, but it has the highest mortality rate. So that introduces a significant risk to mom and baby in the scenario that we're looking at. There's a lot of signs and symptoms. And in addition to this, I just want to say that I think it was 75% or 80% of people also had a concurrent mental health issue at the exact same time. So these are some signs and symptoms, but there could be even more if there's another mental health illness that it's kind of going on at the exact same time. So some things that might be identified physically is frequent fluctuations in weight, extensive weight loss, lack of consistent menstruation. If you lose your period, that's going to be a pretty obvious factor. Inability to meet normal body weight, coldness, fainting, dizziness, lethargy, anything you can kind of think of that's related to being malnourished or a really restricted calorie intake. Constipation, bloating, fine hair growth on face and body, bone and muscle pain, stress fractures, difficulty sleeping. Psychological, we're going to look at as well. So intense fear of gaining weight. We mentioned that with the DSM-5. focus on food, kind of preoccupation with food and preoccupation with body shape, eating, and weight, anxiety, agitation during meal times, shame, self-loathing, low self-esteem, negative view of body, depression, self-harm, suicidality. With both the physical and psychological, it's quite interesting to break these down because these are what you'd be addressing in therapy or at the doctor's office getting treatment. I know sometimes with psychological mental health disorders, there's a lot of like what's underneath that. And there is a lot of work that you can do to kind of break down what's behind the symptoms, but because there is such a safety risk to people's well-being while experiencing episodes of AN or consistent lifelong AN, each one of these signs and symptoms really needs to be addressed for what they are. Behaviorally, there's lots of calorie counting, skipping meals, food avoidance, food group avoidance, and fasting. One thing I thought was quite interesting on this behavioral list, and I won't read all of them, but you can have a look, is the secret keeping is a big one. So in the reading that I was doing, it said that even though a person can have all of these behavioral patterns, their loved ones might not know about it because they're so hidden. So it's interesting to consider how easy it would be to identify in their day-to-day. For an assessment, there's a few different assessments you can do. So it's a real team approach for approaching someone with anorexia nervosa. So you do a physical exam, which is vitals, abdominal exam, height, weight, listening to heart and lungs, skin, nail check, note evidence of self-harm. There's a high indication of self-harm for those with anorexia nervosa, along with like borderline personality disorder or OCD behavior as a concurrent mental health disorder. Let's see. A doctor would also note affect and presentation. Are they trying to hide? Are they coming in super, super baggy clothing? That kind of thing. For a psychological assessment, you can do consistent risk assessments, mental state exam, thoughts, feelings, behaviors around food, eating, body image, and self-worth, identify other mental health issues or trauma. And then from there, you can do bloods, bone density scan, and ECG. So we know that when you are very malnourished or have a very reduced calorie intake, that this can affect your heart, and long-term it will affect your bones as well. So if they have been living with lifelong AN, it would definitely be worth checking. This is our important one for how is this actually impacting our parent-infant relationship. So triggers during pregnancy are weight gain, food cravings, food aversions, hormonal fluctuations, mood changes, nausea, vomiting, exhaustion, insomnia, stretch marks, growth of breasts and hips. It's interesting because when I was doing research about this, it actually said that most moms will reduce their symptoms of AN during pregnancy based on protective factors around growing a baby. But within the 18 months post-birth, they're at the highest risk of relapse. So if they have lifelong AN, or if they just lived with AN when they were younger, it's that point after birth that this can really develop and grow, and all of those anxieties can kind of come back. But what I thought was quite interesting is that even during pregnancy, that is a lot of exposure therapy to past triggers. If you've experienced a fear of all of these things before, having to go through it again, but not have it related to your AN could be triggering. Triggers for after birth is difficulty losing weight gained at pregnancy, permanent body changes such as skin sagging or stretch marks, dieting behaviors, if perinatal depression and anxiety are present, and stress of caregiving. Definitely one of our therapeutic approaches would be to address the perinatal depression and anxiety. It's a very high rate of people with AN who do end up developing perinatal depression and anxiety. However, it's kind of unclear whether or not that is because they had anxiety and depression before, and whether or not that was related to their AN. So it seems all pretty interrelated based on the readings that I did. The risks here to the infant-child relationship is AN relapse, as we said. It's a 75% chance postpartum, or an increase in symptoms if they are going through pregnancy and birth with AN symptoms. Miscarriage, malnourishment to mother and fetus, poor development of baby, low birth weight, difficulty attaching, perinatal anxiety and depression, safety concerns for mother and baby, if suicidality or extremely risky calorie deficits are maintained, and death, as we know. Okay, so here are some medical treatments. As I said, the medical and psychological treatment here are going to go hand in hand. So it's going to be a team of people addressing mom and bubs from here on out. But these can also be applied to those with AN who aren't pregnant or with a new bubs. So everyone can use these. So it would be medical monitoring of health. That's your like regular vital signs, regular blood tests, regular health checks, just to make sure that things aren't deteriorating, and that you can increase your body weight if that was dropping before. Supplements, electrolytes, hydration if they're needed, inpatient, outpatient program or care. In severe cases, a feeding tube may need to be used, but that would be very severe. Meal plans and assistance provided by a dietitian, and medications such as SSRIs for anxiety and depression, and to treat underlying health issues. Because mom is pregnant or breastfeeding, or might be breastfeeding, this is a bit of a tricky one. There's not really many medications that mom can be on at this point, but before and after pregnancy, SSRIs are her option, mainly to treat the anxious and depressed side of what this illness does. Therapeutic approaches, this is going to be where I shine because I'm a counseling student, so I'm going to go into more depth here. There's lots of therapies to treat AN. I wouldn't necessarily use all of them in the the infant-parent relationship situation, like with a pregnant mom, because some can be quite intense and quite exposure-based. And mom is already going through a heck of a lot of exposure just being pregnant. So, but I'll run you through some of them. So cognitive behavioral therapy, family systems therapy, dialectical behavioral therapy, cognitive remediation therapy, intuitive eating therapy, and attachment-based therapy. Now there is one more. It's a version of family therapy, and there is a lot of research on it. However, because so much of the population with AN are teenagers, that's the focus for that therapy. So I've not included that in this scenario. I do understand that teenagers can get pregnant too, and that might be a scenario where that type of therapy is useful. But for this scenario, we're just gonna look at these ones. Just gonna check my time here. Almost finished. Goals of treatment: reduce, monitor risk, restoring healthy weight, expand support network, address anxieties and phobic behavior, explore self-worth, expand narrative around formation of body image, explore family system, explore attachment if needed. That can kind of be a heady subject. So if they're in crisis, probably not where you would start. Process contributing traumas, address concurrent mental health issues and management, and then safety planning for relapse. Application, I'm actually going to let you read through these ones because I want to get to the next slide. So please do go through it. Basically what it says is that during pregnancy, it's going to be more of a medical model, and after birth, it's going to be more of a therapeutic model. But as I said, it's going hand in hand with everyone there to support. It's a team model. So that's going to be there to support mom and baby the whole time, is both. But after birth is when we can do some work, because that during pregnancy is, we want to be kind of gentle to mom in terms of making her unpack all of her triggers. So therapeutic application, this is what I'd be doing for mom likely post-birth. So during pregnancy, my application would be a person-centered approach, really go at mom's pace, make sure that she's getting everything she needs in terms of healthcare, and then really listening to where she's at, supporting if there's a safety problem. From there, after baby's born, that's when I would probably be doing some more work. And to give you some context, I work within a person-centered approach generally, but I would be using an integrated approach for mom and baby here if it's suited. So addressing mom and baby from a counseling perspective is mom's just gone through a whole bunch of exposure therapy unintentionally by just getting pregnant, growing to that size, gaining that amount of weight, and then having baby and still having some of that weight on. So I would be doing some exposure processing around that, understanding what was the purpose of that, how did it serve you, all of that kind of stuff. And then safety skills and monitoring and expanding those supports. DBT and CRT would be kind of next in line in terms of how mom's developing. For me, if that CBT is really working, this would be developing cognitive flexibility, emotion regulation, specifically around fear, pain, and self-loathing, and then pain tolerance tools. This is really useful within that range of postnatal depression and anxiety. If that stuff is kind of starting to creep in again, then we really want to be doing some work around fear and pain and self-loathing, and then how can we self-soothe. Then from there, and I would probably like to have this client for many sessions so that she's being supported all throughout this first year of Bubba's life, is an exploration of attachment. So just exploring the new attachment with baby. How do we interact with them? Are we loving it? Are we hating it? Is there a need to protect, care, love, be present for Bubs? Or is there a real, I can't do this, this isn't me, or look what this has done to me? Really understanding if there's any indications there of perinatal depression and anxiety. From there, definitely some identity exploration and growth, if you can be, understanding roles in life. What does it mean to be a mom? What does it mean to be your own person? What does it mean to be your own person and struggle with symptoms of AN? What does it mean to be a partner if they're in relationship? All of that kind of stuff. And one recommendation I did see everywhere in the research was group therapy in addition to private sessions. It just creates a sense of community and support, and it can be incredibly isolating in that first year, and even during pregnancy in some situations can feel really isolating. So knowing that they're not alone with all of that history of AN is really important. And I think that's it. Thanks so much for listening, guys. Sorry I went quick, but yeah, I think that went well. If you have any questions, flick me an email and I'm happy to try and answer them. Yeah, like I said, you could look at this as well for adolescents, and I would have probably adapted the slides a little bit just in terms of treatment, but this seems to suit our pregnant mothers and new moms. All right, thanks so much, guys. Bye-bye.